So look who I found here. Not by accident, I might say. We're going to have a little talk in a minute. How are you today, Chess?
Somewhere in the middle.
In the middle somewhere.
Yeah.
Right? Perfect. Yeah. I'm sitting here, which is actually my official introduction sentence of all of my videos because I'm not very creative. Like you're a filmmaker, Chess. But more than that, you've turned into a long COVID post-vac science journalist, but that was not always the plan. So first of all, welcome in Cyprus. And second of all, as we see, you're still doing treatments. So that means you're not there yet.
I'm not there yet, no. I mean, I think since I had my second infection, the start of last year, that felt like it took me back to square one in a bunch of my original symptoms and then added some more in on top. And I still haven't quite got back to where I was just before that second infection. So that's what I'm sort of working on now. So right now I'm having some NAD over IV. And again, just trying to shake the tree and see what coconuts fall out. Basically.
Exactly, because some treatments work very well for you, like NAD, hyperbaric, etc.
Yeah.
And the interesting thing is, we figured out that there must be different subsets of long COVID because you and I, we literally did almost the same therapy over the years because we met 2-3 years ago digitally, first time we meet in person, and then we literally copied each other's therapies. But for you, the outcome was a bit different than me, even though for some therapies like HELP, you even had 2-3 more than me. So the 1 year that you had it longer than me and the subset seems to make a huge difference, which leads us to the same conclusion on both of our ends. You in the science section, me in the clinical section, that we need to individualize treatment very much.
Well, hugely. So Professor Carmen Scheibenbogen in Germany, who's an ME sort of specialist in terms of the research she does, she's sort of broken down long COVID into two sort of larger groups, which are essentially those one half that looks, well, I'm not saying it's half and half, but one of those groups looks like ME/CFS in terms of the post-exertional, post-activity related symptom exacerbation, and the other does not look like that. So those, so on that first group that looks like ME/CFS, predominantly characterized by fatigue, post-exertional malaise, cognitive dysfunction, potentially dysautonomia. The second group may be things like muscle weakness and tinnitus and anosmia, and these sorts of and the neurological symptoms. So that's very broadly speaking. So that's one way that we can characterize likely different pathologies in terms of what's causing the symptoms. But beyond that, we can also break down those two groups much further as well. And there are likely to be other pathologies going on inside each of those groups. So even within the group that looks like ME/CFS, there's probably, there's certainly many different systems affected, and there are likely different pathologies driving those symptoms. And I might have, even if we're both in the same group, I might have pathology out of 5, I might have 2, 4, and 5, you might have 1 and 3. So as a consequence, we're going to respond very differently to treatments because it depends what those treatments are actually addressing. And until we've got really clear consensus on what these phenotypes are, and until we've got really good diagnostics in terms of identifying them, so I'm talking about biomarkers there, and again, we're making progress on this front, but we've still got a long way to go. Until we get there, we, to some degree, have to look at doing combination therapies that look to address as many of the possible causes as there are, and kind of sort of see what sticks. And it is as much as precision medicine would be, it's a brilliant goal to aim for. We don't quite yet have the clarity of target to be able to have.
I'm always a bit amused
medicine.
when a doctor says, we do precision medicine in the field of long COVID. And I go like, great for you, but I don't think it works that well yet. Because what we're really doing is, we're throwing things up on the wall and see what sticks, right? Now, I think therapy-wise, we've collected literally all of the good ones. I mean, peptides, MABs, IVIG, they're about to come yet. But I think diagnostic-wise, that's going to be what I'm going to be doing this year. Refining the diagnostics, categorizing the subsets, etc. And we've discussed this before, but in the science field, researchers are always very, very focused on their field and they don't really look left and right, and it's the same with doctors. So it's quite funny. We started off at the same point, getting long COVID. We ended up on 2 different areas that are completely connected though. So you have talked to probably more scientists than anyone else in the long COVID field, me to more clinicians than anybody else, and we both find the same thing. It's very hard for a specialist to look a little bit left and right and connect the dots?
Well, I mean, these specialists have spent 20, 30 years specializing in these fields, incredibly deep depth of knowledge in these fields. And often when they find something out that makes sense, there's a temptation then to try and apply that to everything. And one of the other challenges is that often these sort of breakthroughs or understandings or hypotheses can actually explain almost all of the symptoms by themselves. But that doesn't necessarily, for example, let's take microclotting, which by itself can explain almost all the long COVID symptoms by itself. We can also take mast cell activation, which by itself can also describe almost all long COVID symptoms by itself. But that doesn't mean that all long COVID is one or all long COVID is the other. We've got many of these things going on to different degrees in different people. And actually,
it's an umbrella term only.
Okay, and from the position I've come in from outside as someone who is not a doctor but an engineer, which is to look at, I guess what I was good at has always been sort of analysis and complexity of systems. Yeah. But I come in and I sort of speak to all of these different people and I go, okay, well, there's a lot of different stuff going on here and a lot of theories that can all explain it. And what we're actually seeing and why it's so hard to crack is there isn't necessarily this consistency between patients of, you and me might present the same, but I might have much more mast cell activation, you might have much more microclotting. And those are just two.
There's a little but as well, sorry to cross you.
Yes.
We've cracked a part of the code for a part of the group, and that's where we already have good clinical results.
Yes.
But that seems to be for the same subsets, in the same levels, and we have no prognosis or diagnosis to find out who is in that. So we don't have a crystal ball of glass where we can look into and say, you're in that category. So Actually, I was actually patient zero for combination therapy because I forced my old doctors to give me IVs because of the myocarditis. Then I found antivirals, then the blood thinners, then I found Dr. Jäger, then the help operators and so on. So that was, and then I was the first one who was like, I would say, full recover. Now, doctor wouldn't agree because I still have reading glasses, a cholesterol pill, and the blood pressure pill. But for me, that doesn't. I can do sports, I can do everything where you're not quite there yet. You tried skiing, right? How was that?
I can ski with huge modifications. So that essentially means that the amount of skiing I do is it's like the core rules of pacing, right? Which are do less, do differently, and do slower. And all three of those things I have to apply across to ski. And that basically means that I spend an hour on the mountain. The rest of all of the 23 hours of the 24 I spent resting, much more than I would do. So I can't go back and do Zoom calls and do work and typing and reading.
Well, let's hope in a year or less we have you at the level where I am, because all of the three that you just listed, they're gone for me. 12, 18 hour days, sports, everything. So I'm back to... It seems to be like I made that jump over whatever hurdle that was, where the body then can just go June 2 years ago. And I've done a lot of stupid things since just to test. I've been working a long time. I've been doing extreme sports and nothing made me fall back. So I think once we have patients over that hurdle, over that level, then they made it. But the 1 year after that, that's very, very essential. That's what we figured. Not exact numbers, but pulse anywhere between 95 to 110 in the first 3 months after, pulse anywhere between 110 to 130 in the next 3 months, the first 6 months, seems to be a rather good idea for those people who really go up the ladder and recover. If they don't, we see them falling back, and then we have to give them blood thinners, antivirals, maybe more therapies and so on. So there seems to be these vicious circles that come back when you overexert, right?
And we don't quite understand what's driving it. There's a few different hypotheses for what might be causing that trigger, but we don't yet fully understand it. And that's one of the sort of the greatest challenges, I think, is to understand what that link is between stressors, physiological stressors, and symptoms, particularly in terms of triggering the long COVID in the first place too. So we don't even, our advice to people when they get a COVID infection is rest and convalesce, but for how long? And, we just don't know. The only thing that we do know really is that this is some data that I collected, which suggests that most long haulers can identify a distinct trigger for the onset of their long COVID symptoms. And this was often weeks after their initial infection, up to 3 months. And this is the mad thing, right? Like, what is it that physiologically, pathologically is going wrong when you go for a 15-mile run? What happens in the body then? Why do the wheels fall off in all of these different dimensions? And we haven't cracked that. That would be, when we understand that will be Amazing.
That would be a breakthrough.
Yeah, it will be.
So your and my job will be in the next years to bring in more researchers, more doctors and clinics to do what we do, because it's a little bit, how shall I say, we're the only English-speaking clinic that collects all treatment forms under the do no harm umbrella, of course, that clinicians and patients over the world report. But there seems to be very little going on, except our little island here. And there seems to be very little of coordinated research effort going on. Lots of research in this area, there, but nobody coordinates.
So there was, so my co-author, Professor Danny Altman at Imperial, he sort of adapted the metaphor I used, which was originally trying to describe the long COVID jigsaw puzzle and saying, okay, so it's a 1,000-piece jigsaw puzzle and we've got a few of the edges and a couple of the corners and everybody's throwing in their own pieces onto the board. And then all these different specialists are looking at the pieces on the board and saying, it looks like a train, no, it looks like a steam engine, no, it looks like a car, it looks like a battleship or whatever. And everybody's arguing about what the picture is that we're trying to fill in the puzzle of. But actually, what we might well be looking at, and the reason why everyone's arguing is because there's not just one jigsaw puzzle, there's 5 jigsaw puzzles. And everybody's got the pieces for each one mixed up. And we haven't quite identified what actually are these separate distinctions of phenotypes of long COVID. And that's why some of the data for one, so that's why we get slightly contrasting results or contradictory results to things like treatment trials or biomarkers and the rest of it, because we don't yet have the inclusion criteria to look at just one group, right? So think, you know, in one study, they might look at people, they've got 4 different types of long COVID, and so they treat them and only one group responds. But if we don't understand which of that 25% of those people they are and why, then we look at it and go, well, 75% of people didn't work, it's a negative treatment trial.
But you know what that leaves us with for the next 1-2 years until we have more data? I mean, look back 2 years. We know so much more. We have so much better treatment results. But for the next 2 years, we're going to do the same thing. Broad first-line treatments. Just throw it up the wall, see what sticks. Do no harm, one after the other. That's what we're left with. And I think a lot of medical people don't like to admit that they don't know which therapy works how well for which patient. And maybe that's why they stay away from long COVID and post-vax, because no doctor really likes to admit, I don't know. Right.
Well, that's it, right? And it's a combination of that, but also every specialist has, you know, to them, they look hammers and nails right now. That doesn't make any sense. I have to cut that. You know, what's the expression? Is bit of brain fog. To a hammer, everything looks like a nail. There we go. So to them, in their specialism, they just see everything through the lens of that specialism. And so it's just that one line of treatment which they sort of throw at everything, when actually the real picture involves, actually, until you could work out exactly what you need to strike it with, a broad way of treating is the only way forward.
Well, I hope we're going to find a lot of nails in the next 2.5 weeks that you're still here on the island. We found a few. So let's just hope everything goes well. And let's hope the next time we do this interview in a year, you're going to be in my shoes, where you go like, back then I was like. I really hope we're going to achieve that. And thank you for being here.
Thank you too. Pleasure.
Thank you, Chaz.
Yeah, thank you, Marcus.